Ghaziabad. Informant is mother and reliability is good. Chief complaint of failure to gain weight and height for the last 4 years. History of presenting illness. I would like to start with the index visit. The child was apparently normal till 2012 when developed an episode of hematemesis which was bright red in color and a quantity of 200 ml, not associated with any syncope or postural symptoms or loss of consciousness. Child was immediately hospitalized and was given 3 transfusions and was managed endoscopically. There was no history of jaundice, abdominal distension, encephalopathy during the episode. No history of any need for ICU admission. The child was managed in the ward and was discharged after 5 days. And following the discharge, the child was on follow-up since then. The child was managed with endoscopic intervention at least 5 times till now. Latest was done on August 2017. There is no history of any bleeding in between. There is no history of symptoms suggestive of liver cell failure or mania in between. And now the parents have noticed that there is failure of the child to gain height and weight for the past 4 years, for which they have consulted the pediatrician, and wherein on evaluation with the growth parameters, it was found to have the growth less than 6% and hence the baby was referred for further management. There is no history of any gum bleeding, history of epistaxis, no history of fever or recurrent chest infection, no history of loose stool, no history of abdominal pain or early satiety. Past history, there is childbirth, it was an institutional delivery. There is no history of any congenital anomaly or cardiac disorders, no history of any delayed milestone, no history of jaundice at birth, and no history of surgeries in the past. Family history, nothing significant. Personal history, bladder bowel habits normal, appetite is normal. Treatment history, the child was on Indira since 2012 after the incident. Coming to the examination.
Can you tell me what is your impression at the end of history?
At the end of the history, I would like to keep non-cirrhotic portal hypertension as a possibility, considering the young age and history of index presentation 6 years ago with the history of hematemesis and requiring a repeated endoscopic intervention and history of growth, failure of growth for past 4 years. However, I would like to find out, I would like to rule out the possibility of well-compensated cirrhotic portal hypertension.
So in the exam, you will not be given 2 minutes or 5 minutes to make a differential diagnosis and defend a differential diagnosis. That is question and answer, Q&A. I think we made it amply clear every time, at least I made it clear every time, that you're supposed to summarize the history in 2 lines and then give a list of differential diagnoses. You defend the differential diagnosis based on the summary that you made. And further question and answer can be answered when the examiner decides to ask you more questions. But it seems that nobody seems to be following that. Everybody seems to be following their own protocol. I don't know what goes on.
Yes.
So please summarize the history in 2 lines and then give us differential diagnosis 1, 2 and 3.
Yes, sir. To summarize my case, 12-year-old child with past history of upper GI bleeding, managed endoscopically 5 years ago, and with multiple episodes of prophylactic endoscopic intervention in between, now presented with the history of failure to gain height and weight. I would like to keep differential. I'd like to give a differential diagnosis of non-cirrhotic portal hypertension and well-compensated portal hypertension, cirrhotic.
सर आप कुछ पूछ रहे थे?
No, I think how do you differentiate between, non-cirrhotic includes extrahepatic, right?
Yes, sir. Extrahepatic portal, yes, sir.
At this age, what is likely to be more common?
Extrahepatic portal venous obstruction is the most common.
And what is the etiology you are expecting? What is the likely etiology?
From the history, sir, we have not got any history of any recurrent abdominal infection or umbilical vein catheterization or septicemia. So it could be idiopathic at this point of time.
Anything else you want to ask?
Yeah, all right. I think I can go to the examination now.
Yes. On examination, the child is conscious oriented. Height is 130 centimeter, weight is 20 kg. With the comparing with the growth chart, sir, it comes to less than 5th percentile of the growth index. Pulse is 72 per minute, BP 110/60. There is pallor, there is no lymphadenopathy, no signs of any liver cell failure. Abdominal examination, abdomen is scaphoid, umbilicus is central. All quadrants moving equally with respiration, no scars or sinuses or dilated veins, lines appear free. On palpation, there is splenomegaly 7 cm below the left coastal cartilage, no hepatomegaly, no evidence of any free fluid, no bruit or hum is heard. Other systemic examinations are within a normal limit. To summarize, 12-year-old child with the past history of upper GI bleeding managed endoscopically 5 years ago, and the child is on prophylactic endoscopic intervention with no history of hematemesis melena in between. Now came with history of failure to gain height and weight for past 4 years. On examination, the patient was found to have growth retardation with pallor, and abdominal examination revealed moderate splenomegaly. I would like to give a differential diagnosis: non-cirrhotic portal hypertension, most probably extrahepatic portal venous obstruction, and other one is well compensated cirrhotic portal hypertension.
Okay, fair enough. So how do you want to proceed with investigations now?
Sir, I would like to ask for a complete blood count, liver function test, renal function test, and ask for a Doppler ultrasound of the abdomen.
Yeah, just a tip here. When you start like this with a long history, and in our specialty that's always the case, always start with saying that you want to review all those investigations done earlier if they are available. Sometimes they are given to you, sometimes they are not. Whether it is MC at again, it doesn't matter.
Yes, sir.
So can we have reports of what you asked for?
Sir, CBC hemoglobin is 9, TLC is 2900, platelets 41,000, LFT is bilirubin, total bilirubin is 2.2, SGOT is 29, SGPT 21, alkaline phosphatase is 4, total protein is 7.6, albumin is 4.05, creatinine is 0.5, and INR is 1.27.
How do you analyze these results? Tell me, what is your impression after these results? Are they expected or something is not expected?
Expected results are there, sir. And there is only leukopenia and thrombocytopenia, and slight elevation of total bilirubin, which could be explained with the hemolysis which occurred with this.
Hemolysis because of what? Hypersplenism.
Hypersplenism.
Does hypersplenism give rise to high bilirubin?
Do you have a direct bilirubin?
In case of hemolysis, we can expect there could be some amount of indirect hyperbilirubinemia in hypersplenism.
It is more common.
Let's continue now.
There can be.
What could be more common scenarios associated with this?
More common scenario to have obstructive type of pathology with elevated alkaline phosphatase and GGT. We can expect to have portal biliopathy.
Okay. No, I think in this case, if you analyze, this is a 6-year-old history. So hemoglobin is 9 is acceptable. Hypersplenism also is acceptable. but the proteins are 7.4, so they are fairly good. Liver function appears to be not much compromised. I don't know how much is assuming you said?
4.
4, so that is not compromised. If bilirubin is raised, that should put a question in your mind. Why should bilirubin be raised in extra hepatic portal hypertension? So are you really also dealing with biliopathy or some kind of an obstruction to the clot? So that is something you should also start thinking. Why bilirubin is raised? Because otherwise, is it direct or indirect? What is the kind of bilirubin is raised? Sometimes, there could be a splenomegaly because of some other hemoglobinopathies. But that doesn't seem to be the case here. So we have to think in terms of why bilirubin is raised. So it could be because of mild biliary obstruction. And you will have to really see what is ALP and alkaline phosphatase.
The
What
question
is alkaline
of
phosphatase?
Alkaline phosphatase is 4, sir.
4, it's not raised.
sometimes you will have a patient, and this is a straightforward case obviously, sometimes you will have a patient where the LFT is not still fitting into HPBO. You may have rise of bilirubin, sometimes it can be direct or slightly more than indirect, and you may have a slight derangement of transaminases that falls maybe borderline. So you may be asked to interpret the LFT or hyperbilirubinemia in light of portal hypertension. So you have to give reasons and rationale of how to proceed in those lines. So you said all that, but you've been a little kind of scattered in that. So how do you explain raised bilirubin in a patient of portal hypertension, and how do you interpret it in this context when you get a patient like this?
So if you have direct hyperbilirubinemia in the setting of raised alkaline phosphatase and GGT, possibility of portal biliopathy has to be considered. And in the case of direct hyperbilirubinemia, indirect hyperbilirubinemia in the setting of splenomegaly, there can be possibility of hemolysis as a cause for hyperbilirubinemia.
So you totally disregarded the possibility of liver disease causing this?
There can
and hemolysis leading to stone disease causing this, a disease unrelated to HPBO causing this.
In that setting, sir, albumin level will be low and they can have hepatic type of hyperbilirubinemia.
Yes, so when a question is asked to you in the exam and the LFT is not as clear as this one, the examiner doesn't wish to kind of interpreting you and asking you questions about it. He wants to know how you interpret an LFT which is not clearly fitting into one of the scenarios. So you have to have a list in front of you which can be brought out verbally, and then you can defend which way you want to put your diagnosis as. The way the article by, I think, Sadiq has written it about jaundice and HPBO, probably will go through it, cause of jaundice, and I think it's HPA experience, it's about 10 years old.
Yes.
So we have other centers joining, I think Dr. Pradeep is here and Dr. Puneet is here. Like to ask some questions before we proceed further?
No, actually, it's best the other centers should give their comments at the end, otherwise you'll waste time. But I think what you said is absolutely true. You need to know the LFT abnormalities, another in portal hypertension, and if you say biliopathy first, you're already biased. So it's best to say in order of commonness. If transfusions is one, second is CLD, third is biliopathy, and the rare cause is sometimes a tumor which is causing both compressions on the portal vein and on the bile duct. So both may be abnormal. Especially slow growing tumors like cystic tumors of the pancreas which are compressing there, something like that.
Dr. Pradeep, shall we proceed further?
Yeah, you can go ahead.
Yeah, so you got a LFT now and you wanted ultrasound Doppler. Can we ask for the Doppler please report?
Sir, Doppler liver coarse echo texture, cavernous transformation of portal vein with portal hypertension with portosystemic collaterals.
Nothing more. Spleen, some comment on spleen or.
So that's the problem when you ask for a Doppler study. Then you should ask for ultrasound examination with Doppler examination of the vascular system.
Oh.
Sir, USG abdomen with color Doppler. The liver shows coarse parenchymal echo texture, no focal lesion. There is a cavernous transformation of portal vein. Multiple torches collateral are seen in peripancreatic region, splenic hilum, and beneath the anterior abdominal wall. The gallbladder shows edematous thickening of the wall with varices within it. The spleen is enlarged, measured 40.3 cm. Tiny echogenic foci are scattered in the splenic parenchyma. No free fluid is seen. And splenic vein measures 4 mm at pancreatic level. And it is also normal at the splenic level, 6.1 mm.
Okay, how do you interpret this? Does it fit into your diagnosis, the first diagnosis, or do you think something is abnormal here? You want more information?
So Doppler ultrasound fits into my first differential diagnosis of extrahepatic portal venous obstruction.
Sure.
In the setting of the splenomegaly and portal cavern, presence of portal cavern, and the presence of multiple. Coarse echo texture is unusual in extrahepatic portal venous obstruction.
I think you mentioned abdominal wall collaterals, if I didn't mishear.
Yes.
So why would there be abdominal wall collaterals in a patient who's got portal vein block? Okay, upfront, let me just kind of put it across to you. For all practical purposes, ultrasound examination is an observer-dependent investigation. Always remember that. Because there are times when a dominant collateral is called as a patent portal vein. There are times when collaterals are mentioned, but it doesn't mention where the block is. And there are times when the splenic vein is not seen, but not commented on as obliterated. These are scenarios which are very common. I think the units which are used to dealing with EHPVO come across this scenario very often. So I think it's very important to have, number one, a good Doppler examination by an experienced operator, and number two, interpret the findings in light of your differential diagnosis rather than taking it as is. Because there are times that it does let you down quite often. So here is a scenario where you have findings which doesn't match. So how do you want to proceed from here? So let me put it this way, are you comfortable with making a diagnosis and proceeding with that, or do you want to alter the diagnosis, or do you want more investigations?
Sir, I would like to get a viral marker, and in this scenario I would like to get a viral marker and also possibly a liver biopsy.
How would you define that liver biopsy? Why do you want a liver biopsy?
In the setting of a coarse echo texture and presence of an abdominal wall collaterals.
Okay, the coarse echo texture, yes, it is quite often reported by endocrinologists, and in most cases doesn't mean much, especially if taken in isolation and there are no other features to suggest chronic liver disease. So I think for all practical purposes you can ignore it if the other features don't match the coarse echo texture, or the examiner or the observer doesn't say that there are other features of cirrhosis like quadratic hypertrophy or something else. Abdominal wall collaterals definitely would be important, and if there are abdominal wall collaterals, which basically means the block is beyond the portal vein, intrahepatic or post-hepatic, which means that our Doppler examination should have included the examination of the IVC as well as the hepatic veins. We don't have that information. So that's what I'm asking you, that either you ask for a more stringent examination or you ask for another investigation.
CT, we can ask for the CT photography. CT angle of the abdomen.
We don't do that here, but I can probably ask for input from other examiners for this particular scenario.
No, we also don't do Rajneesh.
Okay. Dr. Puneet, how would you go about this scenario? Abdominal wall collaterals.
I got a phone call. What is the scenario?
Now, the doctor says that there is a total cavernoma and there are close protection of the liver as well as abdominal wall collaterals, apart from other features of the HPV.
Okay, so basically you're worried about Bhatia, is it?
Yeah, the features are not matching, so that the candidate doesn't know how to proceed. He is asking for a CT photography.
So first we would do a CT definitely because it will give us some idea at least about the rest of the picture. Is there any other issues, tumors, etc. We do if the index of suspicion for Bhatia is high, particularly the back veins, we do a IVC gram as well. If there's a doubt, but I mean you need sufficient evidence for invasive investigation to do that before that. But probably before a liver biopsy, because I think his first, I just heard him say a liver biopsy right up front, isn't it? I think we'll have to exhaust all the non-invasive tests before that.
Yeah. So our protocol here is we usually like to do a MR photoinogram if the primary diagnosis seems to be HPV and there are other features which are not fitting into the diagnosis as the ultrasound Doppler would like to suggest. However, if there are other reasons to suspect Bhatia or chronic liver disease, then your approach may be correct. In this particular scenario, my approach would be definitely to do MR photoinogram straight because it will give you all the information you want, short liver biopsy, which means that it will evaluate the hepatic veins IVC for you as well. And possibly if your diagnosis is still HPV after photoinogram, that also enables you to, that gives you anatomy to operate if you are running that particular line in this patient.
Rajneesh Piyush is there. I think we can have an opinion of Piyush.
Yes.
Sorry, I missed what the case is all about.
The ultrasound Doppler which is done is showing all features of VHF, with cavernoma and fetal stomach, but there are abdominal wall collaterals. There's no mention about IVC and hepatic veins. They're asking for
So if we've got a patient who got a Doppler ultrasound suggesting an extrahepatic portal venous obstruction, but a doubt of whether the patient has hepatic venous outflow tract obstruction because of clinical features such as the presence of veins over the back and the flanks, the ultrasound hasn't actually evaluated the inferior vena cava and the hepatic veins, we would repeat the Doppler ultrasound because a non-invasive investigation, easy to do. Don't need to send the patient anywhere, just get somebody to repeat the Doppler and look at the IVC and hepatic vein. If that still doesn't give you an answer, then yes, MR would be an option, CT would be an option, whatever is available to you, both of these would be definitely options. Liver biopsy we wouldn't do very early on in the evaluation of the patient.
Yes, I think 2 points is made very clearly. One is that I think the co-secotexture on ultrasound alone in HPVO, this is for the candidate, is something to be kind of taken with a pinch of salt, especially if it's not fitting into the rest of the features in the absence of chronic liver disease. And the second is that ultrasound Doppler done by an inexperienced operator and give you a bizarre result. So you better repeat ultrasound Doppler or a good ultrasound abdomen with Doppler study with an experienced evaluator. Even after that, if you are nowhere, then possibly I think an approach of either deciding to CT photography or MR photoinogram can be taken. And the choice between the two, especially if you are giving me a patient as young as a child, in our institution is, in children we prefer a CT photography, in adults we prefer MR photogrammetry. And the basic difference between the two investigations is that CT is much faster, and so you can get a much better study in children because you don't have to have a breath hold, or at least a very prolonged breath hold. MR requires a lot of cooperation, so a badly done MR study in a child can be useless. So that's the protocol we follow in our institution. So let's say, have you got more studies after this ultrasound doctor, or are we stuck here?
We have got a CT photography.
Okay, let's have a CT photography, please.
Hello, hi. Can I just make a point? The disease of EHPV in the south is slightly different from what we see in the north. We do see adults with EHPV, so especially in the scenario that you said that there could be IVC obstruction as well. I think we need to do and if it's the disease is coming in adults, we do need to do a pro-thrombotic workup as well, because later we lose that opportunity probably.
Yes, I think I will push that point, and there are times you will get a patient who is, say, for example, 20 or 25-year-old lady who's got also possibly history of rectal abortions. So in that kind of a scenario, you definitely should ask for a pro-thrombotic workup. In my personal opinion is that you should ask for a pro-thrombotic workup in every patient with EHPV. Unfortunately, in a younger patient, it doesn't make a difference for treatment. Apart from anticoagulation, which most of us don't do, and therefore we don't ask for it. But yes, I think in a pure theoretical sense, a pro-thrombotic workup is definitely on the cards. But here is a scenario where he has doesn't have a confirmed diagnosis, so I think he may be wanting to reserve it for a little later. Can we have a CT photo then?
CT. No, I would say you can show the film.
Sir, shall we tell the reports?
Yes, if you don't have films, let's have a report.
It's been put up in the presentation. I think somebody has to project.
Okay, maybe you can read out the report then, because most of them don't seem to have it.
So the triphasic CT abdomen suggests liver is contracted in size and shows mildly lobulated outline with prominent caudate lobe, no enhancing focus mass lesion seen in arterial phase. Gallbladder is distended with tortuous pericholecystic collaterals, portal vein and its intrahepatic branches along with distal SMV and distal splenic vein is replaced by multiple collaterals, portal cavernoma with collaterals seen along the gallbladder wall and along the common hepatic duct and proximal CBD with resultant mild dilatation of central IHBR, dominant channel seen in region of porta draining into the SMV. Confluence of SMV splenic vein is not visualized with dilated and tortuous splenic vein measure about 8.5 mm at splenic hilum. Collaterals also seen in the gastrohepatic region, G junction mesentery with linorenal collateral draining into the left renal vein. Left renal vein is normal in course and dilated, mid-segment diameter is 9.4 mm. Afferent limb of the linorenal collateral shows mild segmental narrowing approximately 13 mm away from its junction with left renal vein query thrombosis. The afferent limb measures 8.5 mm just before its junction with left renal vein. Collaterals are also noted along the inferior mesenteric vein. Mid SMV shows normal contrast opacification without thrombosis. IVC shows normal caliber with contrast enhancement. Spleen is grossly enlarged in size 15.5 cm with mild post-contrast heterogeneous enhancement.
Any comment on hepatic vein?
No, sir.
The films the cover. Yeah, only in this case.
Have you looked at delayed penetration?
फिल्म्स है इसकी कहाँ से फिल्म बनानी
So we have a report which comments on the hepatic veins and hepatic collaterals, so we don't have that report.
No, sir, there is.
दिखाना मेरे को रिपोर्ट
So we are stuck in the middle, right? We have a study which doesn't give us adequate information about what we wanted to see. The films you provided to us are all arterial phase. We don't have the venous phase. From the venous phase, you can interpret it yourself and tell us whether there are findings which suggest hepatitis or not.
Yes, venous phase. You should have got the films analysis information. ला दिखाओ
Can I make it easy for you? I think normal, there are no normal collaterals, and the hepatic veins show which are patent, and there are no intrahepatic collaterals either. The CT is suggestive of portal cavernoma, and rest of the findings I think this time. So what is your plan?
Yes. Sir, I would like to get an upper GI endoscopy. I would like to repeat an upper GI endoscopy in this.
What's the advantage?
So we have endoscopy now currently.
Yeah.
Upper GI endoscopy done on August suggests your portal hypertensive gastropathy and eradicated esophageal varices.
Is that all information you wanted?
I wanted to look for any presence of ectopic varices in the duodenum and the stomach.
We haven't given it to you, so you have to ask the endoscopist again. So let's assume that there are no gastric varices, there are no duodenal varices till the point where they could see.
Cancer?
Assume there is no duodenal varices in this.
Sir, in the CT photography, we have got lobulated liver with the with the caudate lobe hypertrophy and presence of abdominal collaterals and patent hepatic vein. I would like to look for any cirrhotic changes in this patient.
How do you look for the cirrhotic changes?
We'll have to go for a liver biopsy.
Okay, fair enough. Other centers would like to input? Maybe Dr. Piyush can give his input about the choice of liver biopsy at this point. The CT photography apparently shows liver which is lobular and caudate lobe hypertrophy.
Do we have a liver function test?
Yes.
So the normal liver function test with a normal INR with a normal albumin, I would take that caudate lobe hypertrophy with a pinch of salt. Do we have viral markers on this patient?
Viral markers negative.
So, in a 12-year-old who's had 5 years history of GI bleed, why would we think in terms of cirrhosis with everything pointing towards extrahepatic portal venous obstruction?
So because CT is showing that there is evidence of lobulated liver and caudate lobe hypertrophy and presence of abdominal wall collaterals.
No, abdominal wall collaterals can be there in any patient with portal hypertension. Specifically located on the back, they would suggest that there is obstruction to the inferior vena cava. So I don't think we can extrapolate one finding and then go ahead and say this is my diagnosis and everything else I'm going to ignore and put into the dustbin. That's not fair, I think. I think here's a patient who's got a history of GI bleed. You have inadequately reported on investigations. I think to jump to a diagnosis of cirrhosis or hepatic venous outflow tract obstruction and then want a liver biopsy would be unfair. Yes, if the liver is actually shrunken, small, fissures widened, some ascites, yes, of course, liver biopsy would be an option. But prior to doing that, I would get somebody to say, look at the IVC, look at the hepatic veins, see what is happening there. If we say that the IVC is normal, the hepatic veins are normal, there is extrahepatic portal venous obstruction, and the child has been bleeding since the age of what? 6 or 7 years of age. Then we must look at what are the possible etiologies for cirrhosis in this patient. Taking that into context, then obviously liver biopsy would be indicated, but only if you are absolutely sure that this is chronic liver disease and nothing else. If you think it's chronic liver disease, if you think the liver is grossly abnormal on imaging, then yes, of course, a liver biopsy would be indicated. So I would still want somebody to look at the IVC and the hepatic vein and be absolutely sure. So Rajneesh has given us a hypothetical situation to go ahead with the discussion of the patient. But in that situation where the hypothetical situation of an IVC and a hepatic vein being patent, I'm very skeptical of what is happening to the liver without any underlying, reason for the liver disease. So then you're looking at very, very rare conditions which at the age of 6 would have caused cirrhosis. There aren't that many. You're looking at a few congenital indications. 10-15 years ago, you would consider things like Indian childhood cirrhosis. Now you don't see them. So it's not something that's something that's common garden variety of portal hypertension which you need to go ahead and treat. I think you'll need to really look at this patient much more carefully.
Yeah, one way I can help you in this decision making to the candidate, that is, right. So, you want to say that one way to say moving forward in a scenario when you are faced with an invasive investigation, whether you should do it or you shouldn't do it, would be to kind of put it in light of context of what your plan of management is. If that investigation which is being proposed or you're thinking of it seems to change what you are planning, then it may be justified to do the investigation. So let's come to a point where you have a plan of action now in this particular case. Then you decide whether you need to biopsy to change the plan.
I think all the centers have their mics on and having the internal discussions.
We can hear all the internal discussion here. So to Gangaram, please, can we have a plan of action now?
Sir, well-tolerated esophageal varices with the non-cirrhotic portal hypertension in a young age and presenting with growth retardation in a pubertal spurt age, I would like to consider surgical options for this patient. Explaining the after explaining the options with the patient parents.
to my mind, this approach is quite strange. You know, every time I see candidates do this, first the rationale and then the treatment. Nobody asks you for a rationale. We ask you what your plan of action, and then you can leave it to the examiners to ask you questions about what your rationale is. What is your plan?
Sir,
What treatment will you offer to this patient?
surgical management, sir, in the form of proximal sclerorenal shunt.
Right.
So you'll have to give a plan. I mean, here we don't have a diagnosis on the liver disease yet. Are you going to do a PSRS on somebody who don't know liver disease? So you need a sort of a plan to say, this is what I need to see and this is what I want to do if this turns out to be this. That is a plan. Okay? Don't just give a sort of diagnosis.
I think what he means to say is that at this point, whenever the liver biopsy change your plan, so that is what the examiner wants to hear, that you are thinking rationally in terms of how, if the total liver biopsy is required, or else do you want that finding to be interpreted during surgery.
So liver biopsy will definitely change the management because it is a well-tolerated esophageal varices, and if the biopsy comes to be cirrhotic, then patient needs to be on follow-up, and it needs to be. We have to rule out the possibility of cirrhosis in this.
Patient has not bled for almost last 5 or 7 years. Right now, you are only doing prophylactic sclerotherapy. So, are you going to do now surgical treatment only for stunted growth?
In absence of cirrhosis, sir, yes, and also if the child is on repeated prophylactic intervention, and in that scenario, the literature has suggested that there can be possibility of development of ectopic varices and chances of bleed. So, in the absence of cirrhosis, yes, sir.
Okay, so if there is cirrhosis when you operate the patient, will it change the approach?
Yes.
Yes, sir.
So you plan not to operate if there is cirrhosis?
Yes, sir. If there is cirrhosis, I would like to keep her on conservative endoscopic management.
Yeah. So the combination of cirrhosis with portal hematoma, portal hypertension, EHPVO is a very rare combination. There is EHPVO, you can see that. That is pretty apparent on the investigation that you have. From what I remember from the AIIMS days, that the number of patients who have cirrhosis and EHPVO would be very, very rare. So unless you have clear features that point to cirrhosis right before you operate the patient, liver biopsy is usually not on the cards. There may be occasional patient where during surgery, when you operated for EHPVO, you find the liver is not really healthy and you would abandon a shunt at that point in time. But that is a calculated risk you would be willing to take.
Yes.
Dr. Piyush, would you like to put some inputs?
So, if the patient has extrahepatic portal venous obstruction and there is some doubt on whether or not the liver is okay, our approach generally in patients where there is an indication for surgery would be to go ahead and operate the patient with the plan to do a shunt, but if intraoperatively the liver did not look normal, i.e. had changes suggestive of cirrhosis, we would then defer the shunt or sort of abandon the shunt and instead do a splenectomy and a devascularization. Here I think we have a little more difficulty because there are some features clinically to suggest hepatic venous outflow tract obstruction. B, we have investigations which aren't sort of totally with us, at least the imaging, and therefore that approach could be one possibility. The other possibility could be preoperatively do a liver biopsy if you very strongly suspecting cirrhosis on imaging, and then go ahead and take a call on that. So both approaches are on. Our approach generally in patients with extrahepatic portal venous obstruction has been to go ahead and operate, and if there is intraoperatively evidence of cirrhosis, then to go ahead and do a splenectomy and a devascularization. The fact that she has eradicated varices would not deter us from going ahead, because we believe and we've sort of reported our case series and published this, that in extrahepatic portal venous obstruction a prophylactic shunt works well. So in her, considering that she has growth retardation, I believe the people who've seen her that she is growth retarded, I presume she's shorter than her sibs, has grown, her developmental milestones have been slower than her siblings, and so therefore that would be a major consideration at this point in time to offer her a surgical procedure. But the doubt would still remain as to what is there something else, and if there is something else intraoperatively, be prepared to abandon or not do a shunt and just do a devasc.
Yes, I think I would agree with that approach. In a given patient where the VHPV are definitely the alternative diagnosis of chronic liver disease is uncommon or rare, that would be the right word to use. But if you have investigations which strongly point to the presence of coexisting chronic liver disease, only and only then I would ask for a liver biopsy upfront. In patients where investigations are, one investigation gives you, for example, ultrasound Doppler shows you a post-liver on the echo texture, but all the rest of the investigation seem to be all right, synthetic functionality looks good, and your plan finally is to offer a shunt. Then intraoperatively you can assess the liver and take a decision. And I don't think there are many patients, very uncommon patients, where you would abandon a shunt based only on intraoperative examination. So my question to you would be, let's assume for a minute that you have a normal liver, because the debate has gone on for too long, and you have a patient of VHPV or eradicated varices. The next debate which usually comes up in the exam is why offer a shunt, and I think Dr. Supe, Dr. Piyush have touched upon these issues. So you will have to defend a shunt. So how would you defend your shunt?
Sir, in young age and with the growth retardation and a major bleed in the past, and in the age of pubertal spurt, I would like to go for a surgical option, sir.
So the counter to these arguments usually is the absence of data. So you will have to also tell us data which exists both for all these soft indications which tell us that the shunt is better than not doing a shunt.
So there are, the literature suggests that even in the presence of endoscopic eradication of varices, there can be possibility of ectopic varices and development of portal biliopathy and risk of major bleed and mortality of 14% in them. And also there are literature suppose that the growth retardation are reversed once when the patient is subjected for shunt operation.
Rajesh,
Before the puberty.
approach which Piyush has suggested is absolutely perfect, because this is pre-pubertal. And if your liver is normal, I think definitely you would like to go ahead and do a shunt. And I think the preferable shunt here is definitely the linear proximal linear. That is not the question. I think most of who would do this approach. The only question here is that her age is around 12, right? Or 13?
Yes, 12.
So that is the right age for this shunt. So if you do it pre-pubertal, there is enough data which shows that if you do pre-pubertal, the stunted growth really improves. So you are in the right age, and therefore I think a shunt, if the liver is normal, is acceptable. My question would be that by investigation, if find the hepatic veins are not normal, or there is a doubt in that hepatic veins, would your approach change?
Is that question to the candidate?
No.
To me?
Candidate, question to the candidate.
Yeah.
Because I think Piyush and I think we agree with Piyush about if liver is normal, I think we are clear now. If the hepatic veins are abnormal, what would you?
So in that scenario, well-tolerated esophageal varices, I would like to keep her on endoscopic surveillance. And
So you need to state the problem. I think it's you. First of all, you've been very casual in giving your case presentation on in the group. You haven't given the age, gender, clinical findings at all. So I think in the exam also it's unacceptable. You'll get less time in the exam than what you had to prepare the case. So we don't know actually what is the problem now with the patient. So if bleeding is a major problem, then we are worried, whether this is not a prophylactic shunt either way, the patient has bled. So it would need a shunt if it's appropriate. But we need to know, so you need to give us the options, what the patient is now, what brought him to the hospital. Was it the growth retardation? Was it hypersplenism? We are not clear on that. We were disconnected during that time. So all that needs to be brought out, and you need to give your options that if in a case where the liver hepatic veins are in doubt, you need to have a prothrombotic workup as well, because this is a slightly younger patient, but even then I think you need, like Rajneesh said, you need to have a prothrombotic workup also there. So I think you need to give the option that you have a non-operative approach, a surveillance approach, what Piyush suggested about a possible DVASC in case you go ahead with the preemptive diagnosis of normal hepatic veins and then take a call from there. So you need to have all that in your algorithm when you speak.
considering in the background of young age with the abnormal hepatic veins and well-tolerated esophageal varices, the only problem the patient has brought in with us is for growth retardation, and and she has not bled for past 6 years. She's on repeat endoscopy suggests that there is eradication of esophageal varices and there is availability of tertiary care center with them. So I would like to consider her for endoscopic surveillance in that scenario, and if there is an abnormal hepatic vein.
So if you're going to treat a patient with hepatic venous outflow tract obstruction, if there is no cirrhosis, then I think decompression has to be done. If you don't decompress, she will become a cirrhotic. If she is already a cirrhotic, then you need to consider a workup for a possible transplant at some point in time. She isn't decompensated right now, so obviously transplant is not indicated, but maybe an option. In that scenario, prothrombotic workup is definitely on the cards. But if a patient has abnormal hepatic veins, has hepatic venous outflow tract obstruction, you will have to do some form of decompression of the hepatic venous outflow or restore the hepatic venous outflow. Otherwise, you're sure to get the patient to end up with chronic liver disease. So you can't keep her on endoscopic surveillance. That's not going to be an option for a patient who has hepatic venous outflow tract obstruction.
I agree. The only complicating problem here would be how do you decompress the hepatic veins, and in most scenarios, I think it is intervention radiology with recanalization of the vein, putting a metal stent in. The problem would be putting the patient on long-term anticoagulation in the presence of a bleeding lesion. So in this scenario, the varices are eradicated, you can easily put the patient on non-end coagulation. What is the portal hypertension because of can possibly be judged only after you decompress the hepatic veins. How do you assess that? Well, in the absence of varices, it will be very difficult to assess whether decompressing the hepatic veins would decompress the mesenteric and splenic circulation and relieve the portal hypertension. But I would definitely endorse what Dr. Pooja is saying, that if you have venous outflow tract obstruction and you leave the patient without relief, he is going to end up with cirrhosis. There is absolutely no doubt about
that. I think this is the window, most of the time, at this window, patients are only surveillance and then they miss and they come with a cirrhosis at the age of 16 or 17. So I think if you have even a small doubt about hepatic venous obstruction, this is the time to explore more, do more investigations and decompress, because this is a window, if you can do it, you can save the patient. Otherwise, most of the time patients come very late and they do have only option of either transplant or they allow them to deteriorate. So this is a good window if you have hepatic vein obstruction, decompress it. Maybe you can do interventional radiology, stenting or something like that. This is the time when they will really respond. After some time, then it's very difficult to manage.
I think he's talking about some older studies, where they showed the liver biopsy being predictive. Sheila Sholak, I think, mentions this, that whether the phase is congestion, fibrosis, cirrhosis, etc. Congestion, necrosis, fibrosis, cirrhosis, and then you can act accordingly. But I think that's very theoretical because there's a huge variation from sampling and all that. So you might get a wrong area, and not even we found patients even with sort of a differential cirrhosis when they're explanted. The second point I wanted to make was, Piyush mentioned that transplant will be an option in end stage. Sometimes in Bhattacharya, you don't have to wait for the end stage renal disease, liver disease to transplant. It might be an option even earlier because if the prothrombotic workup is, sometimes the liver itself, the placement of the liver can correct the prothrombotic condition. So you don't have to wait for end stage alone. It might be considered earlier. Of course, it's a little more complicated if there's EHPV as well because you need to do a lot of maneuvers can be done. I thought that's a question which should come up. And Sudhi here has a paper on one of the unusual ways of dealing with it, the KO portal, hemi-transposition. So there are a lot of options that you need to know what to do, how to manage a transplant when the inflow is also obstructed.
Yeah, I think the case possibly that it shows.
Rajnish, I think we have now 5 or 10 minutes. Any questions for the PG?
Yeah, I actually was deliberately trying to take the discussion away from two diagnoses because that's not the usual scenario you get in the exam. The usual scenario you get in the exam is an EHPBO, and the more usual discussion that centers around is that why offer surgical on the patient who's got either eradicated varices or asymptomatic hypertelorism or is already 20-year-old and so therefore the growth spurt is already gone. Those discussions to my mind will be more relevant in terms of the numbers you encounter more often. And possibly in the exam, that's the discussion usually that takes place. So I would be happier if you, that's why I was asking him, when you offer a shunt, what would be your rationale? Because a hard indication for a shunt in today's day and age is usually uncommon. It's there, and it's usually uncommon. And more common scenarios are when you have multiple soft indications. That's what the discussion in most cases revolves around. So I would be really interested in you reading up indications, soft indications, which you mentioned, because at times the discussion goes on to the specific studies which you are quoting. For example, the improvement of the growth spurt. If you really look at those studies very carefully, they can be criticized to no end. So you have to be aware of these studies about each indication which you mentioned. including the presence of ectopic varices later on, including the presence of biliopathy later on. To have natural history studies, we don't have any. This is all conjecture, not exactly conjecture, but I guess more of follow-up data which we base it all on.
Piyush,
Yeah.
Piyush, I have a question for you. Now, and I think what we have discussed is, and all of us will do shunt in the case if the hepatic veins are normal and the liver is normal. Now, in your opinion, has it reduced the incidence of portal ileopathy if you do a shunt or if you don't do a shunt?
So, I don't think we have enough data to say that, but we do have a case series that we followed up, compared with controls, and we think that patients who have had endoscopic interventions seem to be a risk factor for the occurrence of portal biliopathy. Now, whether just following up a patient without any endoscopic intervention, there is a higher proportion with portal biliopathy, I can't say. There is some data from case series which seems to suggest that portal biliopathy seems to occur in older patients. This would suggest that the natural history would be that if that is true, then it would suggest that if patients live longer without any intervention, they're likely to develop portal biliopathy. So I think these are pieces of information that we have, but we don't have enough hard evidence to say one or the other that something, whether just age is a factor, whether interventions are a factor, and whether just doing nothing but an older patient would be the reason for portal biliopathy occurring.
Do the candidates have any questions?
Yeah, that's Piyush, an extension to what Super has asked. Comparing endoscopic versus the shunt developing portal biliopathy, my question is, you do devasc. You devasculation, you are damaging more of collaterals. Devasc patients only without shunt versus those patients who are shunt. The incidence of developing portal biliopathy.
So there is a series from Gangaram which has actually suggested that doing a devasc improves portal biliopathy. It's a small series, but it is series nonetheless. So I don't think we again have enough data to say whether devasc actually harms a patient with portal biliopathy. So I would again say that speculation as to whether it harms the patient or it makes no difference whether you do a devasc or not. So that's what we know. Can't go beyond that.
One thing which didn't come across very well was the ultrasound expectations. Can the guy who presented today give a 2-minute presentation next time and upload it on the group on what all you expect? Because when you go to a peripheral center, you're happy with a routine ultrasound finding. As Piyush said, you need to have a focused person to do it. So unless you know what you want, he's not going to be able to provide you. So can you just give a 2-minute presentation on what all you want to see on on an ultrasound, including hepatic vein, the renal vein, ascites, etc.
Yes.
So does the presence of splenic artery pseudoaneurysm has an impact in decision making of shunt surgery? I think Dr. Piyush possibly could take that question if possible.
Hey, come along, that's not fair. I think if a patient has portal hypertension, has varices, has bled from varices, irrespective of whether or not the patient has a splenic artery pseudoaneurysm, the option is to decompress the varices, and the surest way of decompressing those varices by doing a shunt. Now, a splenic artery pseudoaneurysm or an aneurysm could actually make your life difficult, because getting the vein off that aneurysm may be tricky and you may not get enough length. Now that would mean that you may end up with a DVAS. But given a choice, unless you can say there is an arteriovenous communication and you are going to disrupt the communication and therefore lead to a change in the portal hemodynamics, which should lead to a decrease in the portal pressure, I think you still need to decompress the portal venous system. So just the aneurysm wouldn't be enough for me.
I would divide this into, these are very uncommon scenarios that do occur, that the MR or the CT study shows you, in addition to HPV or small aneurysm of the splenic artery. So I would divide this into two clinical scenarios. One is the small aneurysm sitting there, which you are not really too much interested in. You are really interested in what Dr. Piyush mentioned as decompression of the portal system, so you go ahead with the shunt. And that aneurysm will not interfere in your management and in your surgical dissection in any way. The other scenario is a large aneurysm, where it would make it very difficult to ligate the splenic artery at the superior border of pancreas, which you usually do before you start off to dissect the vein. And the other would be whether a splenic vein associated with the large aneurysm would make it very difficult to get it off the artery. In the occasional scenario which we've done in a huge aneurysm like this, what we've done is place a balloon catheter at the neck of the aneurysm transfemoral, taking the patient to theatre, and then during surgery decompress that. So how it helps is that the aneurysm size and the cleanliness reduces, so we're able to dissect around the aneurysm. That's a one-off scenario. It's very difficult to extrapolate it to most majority. The majority of scenarios, the aneurysm doesn't really interfere with your decision making or your dissection in most cases, except in a huge aneurysm.
So one question, sir. In today's case, as the patient is a 12-year-old with growth retardation, and there is a portal vein obstruction extending into up to the confluence involving the distal SME and splenic vein, and there is suspected hepatic vein thrombosis. What would be the kind of decompression would be better for her? What kind of decompression would be ideal for the such a scenario? This is a finding as per the CT photogram, which shows that there is a non-visualization of the confluence extending into the proximal splenic vein, the distal splenic vein and SMV. And sir said that if hepatic venous outflow obstruction is also there, there should be some kind of decompression which has to be given. And what kind of decompression, what would be the plan of shunting in such a patient?
I think Dr. Piyush again was suggesting a shunt in this scenario. Right, let me take that. So, there were instances, I think, in the database, they're still there, of patients with Budd-Chiari undergoing proximal aneurysmal shunt. They didn't do well. From what I remember, because I remember my first shunt was Budd-Chiari, and they pour ascites from the. So I don't know whether they're still doing it for Budd-Chiari or not, but I don't think a shunt is a very good idea for a Budd-Chiari today. You have better recanalization options, and that is, in most instances, interventional radiology with a metal stent placed in the hepatic vein ostia. Of course, if the patient is already cirrhotic, then as Puneet said, you have to consider a transplant. In this particular scenario, you have Budd-Chiari with ESTPO. I think the first thing to do would be to recanalize or try to recanalize the hepatic veins by interventional radiology and see where we go from there. If you are able to recanalize the hepatic veins, put the patient on anticoagulation and re-evaluate the need for shunt for ESTPO, because a shunt would be fairly complicated in this scenario. I'm not sure what the other groups would do. We can have input from other groups.
I think if there is no shuntable vein, the only option left at this point would be a transplant.
Maybe transplant is going to be a difficult thing if there is no inflow. How do we get the inflow for the transplant also? So I mean, it's a very difficult, the scenario that they outlined, I thought the mesocardial was still possible, and that's what we would do at least if the patient is well compensated. But I mean, in the absence, if there's diffuse thrombosis, even transplant, the inflow is going to be a problem. So, one of the options, of course, chemoportal vein transfusion, but it's a very, very difficult scenario even in transplant setting.
Right, there you are. So you don't have a clear answer to your question. But my contention was very clear that doing a shunt only for PCI would be off the cards. But if you're doing it for ESQ, then you can think about the options that you have.
I think recanalize the hepatic vein, and if you can recanalize the hepatic vein and there's no need for a shunt after that by follow-up, then you can stop there. If recanalization of the hepatic vein doesn't treat the patient completely, then you can do a shunt, add on a shunt. That would be a rare scenario. The second option or the other option, if recanalization fails, transplant would be one option, but if the liver was normal, then doing a linear shunt could be an option if the splenic vein is available, or if the splenic vein wasn't available, as Puneet said, if the superior mesenteric vein is available, then one would consider doing a mesocaval shunt. So essentially what you are doing is the first step, trying to decompress some system as long as that is possible. If that's not feasible, then obviously the option of a transplant would have to be considered.
Right, we are at 14. Unless you have closing remarks, we should be closing up.
Good, thank you.
Thank you very much.
Thank you.
They anticoagulate everybody. Basically, it's come from pediatric surgery there, which are propagated.